This is the lecture that goes with Chapter 11, Posture and Body Mechanics. So if you have the open outline, a hard copy or the electronic copy, it'd be good to have that next to you right now. And you can go ahead and follow through with the lecture and then fill in the outline as needed. So first of all, we talk about posture, which is relative alignment of various body segments with one another. And proper posture will reduce undue body segment stress. So sometimes just posture alone can cause pain. So we need to understand what normal posture is. It's useful in the evaluation of chronic injuries. That's the first thing to fill in on that top line. The second one is posture evaluation aids in developing proper exercise programs and positioning. And then finally, we want to understand posture because it will help you aid yourself in conserving energy and preventing energy when you do techniques such as joint mobilizations or PNF or strengthening. So correct standing alignment using a plumb line. This information is on your lab sheet, worksheet for PNF or for posture evaluation. So rather than going through this detail by detail, I think it'd be helpful just to go ahead and write down when you have a plumb line what the standing posture, how do you align somebody, their starting position, and then what landmarks should be bisected, and then what things should be level. So from a frontal posture view, this is how your plumb line lines up. You did this in lab. Posture view, posterior postural view, again you did this in lab, and then the lateral view. So you should have all of that information. Go ahead and just transfer that now into your notes so that you have it in a place that's easy to study for this in the exam. Below that you have a correct sitting alignment space, and so the thing that I wanted just to review on this was what we call the 90s. So a correct sitting alignment when someone is in a chair, the ankles should be at 90 degrees, the knees should be flexed to 90 degrees, the hips should be at 90 degrees, the elbows should be at 90 degrees. So that would be correct. Sitting posture is in the posture of the 90s, 90 degrees in all of those joints. So you can look at that. If you have a chair that you're working in that's adjustable in height, you might want to try to see if you can get your sitting posture so that you have 90s in the ankles, knees, hips, and elbows. Moving on to pathological alignment. So here we're going to talk about alignment that can lead to decreased efficiency, abnormal stresses over a long period of time, because some muscles will become shortened due to posture and some will become lengthened. We typically don't take specific measurements of this, so we don't quantify this information. It's actually a qualified material, and we'll write down either mild, moderate, or severe abnormalities. So we might write down a mild, moderate, or severe limitation in hip flexibility. So that's typically what is done with posture. However, you could take objective measurements. So the first one is we look at lumbar lordosis, otherwise known as sway back. For lumbar lordosis, somebody has an anterior pelvic tilt, and if we take a look and palpate from the lateral view, we put a hand on the ASIS and compare that to the PSIS. The ASIS is typically down in position, and the PSIS is up, so it's not level. Let's see if I have a picture of this. Oh. So in this case scenario with the lumbar lordosis, there's certain muscles that we'll typically find that are shortened just because of the posture, and they become tight. Those muscles will be the hip flexors on the front, and then across on the back, the back extensors. So tight muscles with somebody that has a lumbar lordosis posture would be the tight hip flexors and tight back extensors. We'll also see weaknesses in muscles that are elongated, and with the lordosis, typically the abdominals tend to be elongated, and the hip extensors tend to be weak and elongated. So make sure you get those written in. Tight hip flexors and back extensors and weak abdominals and hip extensors for someone with lumbar lordosis. So if that was found on your posture evaluation, you know that there's a couple muscles there that could probably use some stretching, and there's a couple muscles that are weak that could use some strengthening, so you could come up with some corrective exercises. A flat lumbar spine, somebody tends to be in a posterior pelvic tilt, so the ASIS is up and the PSIS is down. However, if those are perfectly level, somebody will still look like they kind of have a flat back, even though the ASIS and the PSIS are on the same plane. So muscles that we typically will see that are tight with somebody with a flat lumbar spine, the hip extensors and the abdominals are typically a little bit tight, and then the long ones, muscles that are longer and weaker, would be the hip flexors and the lumbar extensors. So just the opposite of a lumbar lordosis. We don't tend to see flat lumbar spine very often. It's not as common as a lumbar lordosis. If, however, you did see these postural deviations on your own posture evaluation, there are some things that you could address then, stretching out the extensors and the abdominals, and then strengthening the hip flexors and the lumbar extensors. Thoracic kyphosis, actually a fairly common finding, anywhere from having more of a sway in the kyphotic curvature to a severe kyphosis. We see this primarily in the elderly, if we do see it. Often associated then with an excessive lumbar lordosis because they try to compensate for the excessive kyphosis. What do we see that's typically tight in somebody with a thoracic kyphosis is their pecs are tight, the lats are tight, and the serratus anterior is tight. So that's the pecs, the lats, and the serratus are typically tight. All these muscles on the front here, as they kind of have that rounded shoulder and forward, and then muscles on the posterior part of the thoracic spine are usually weak, so that's the rhomboids and the middle and lower trap. So there's some exercises that can be done to stretch out those tight muscles and then strengthen the weak muscles, and we'll see how you do in coming up with some ideas on those before we actually get into different segments of that. But do your best, see what you can find if that was a finding for you. So when you did the plumb line, if the depth on the anterior chest was less than the posterior, it's likely that you perhaps had thoracic kyphosis and that you need to stretch out the anterior, the pecs and the lats, and then strengthen the rhomboids and the middle and lower traps. A frequent finding then too is also if the scapula is greater than 2 inches from midline. That's a pretty good indication that somebody has an increased thoracic kyphosis. Just another example, a little cartoon picture of what kyphotic spine looks like on this slide. All right, a scoliosis. We've got a mild scoliosis. It can be a C curve, so we just have one curve, or it can be an S where it kind of goes one way and then back the other direction. Tightness and weakness with the scoliosis, typically they're going to be tight on the concave side. So the side of the curve that's on the cave side would be tight, and then they're weak on the convex side, so the opposite side. So it's kind of difficult sometimes to stretch out those muscles, but you can certainly do some strengthening activity. So here we go again. It would be tight on the concave side, so in the up by the scapula, she'd be tight on the left side on the concavity, and on her right, up by the scapula, we'd have weakness over there. So she would be doing strengthening exercises for the rhomboids, middle traps on this side, and perhaps some stretching of the paraspinals on the concave side, in maybe a sideline position like over a physio ball or a Bosu balance apparatus to see if we could stretch that out. I have a little note to the side of that says scoliosis versus a lateral shift. So this is just a reminder that sometimes people will come in and they'll actually have a shift so that the hips and the shoulders, so the shoulders are level and the hips are level to each other, but they're simply shifted over. So it's like somebody pushed them lateral. And typically this is a posture with somebody that has back pain, and it's not a scoliosis. It's simply a posture to avoid increasing their back pain. So those same rules of tight on the concave, weak on the convex side are not true with somebody that actually has a shift, because they don't have a true concavity or convexity in their spine. So just wanted to make a quick note of that. For forward head posture, we can see that we have an increase in cervical lordosis, so forward head. So this would be normal here on the left, getting further into a cervical lumbar or cervical lordosis, and on the far right is severe, also known as a forward head position. So some of you, your plumb line maybe didn't line up, or you in front of the plumb line, and that would be indicative of having cervical lordosis. So what we see here is increased lower cervical flexion, and increased upper cervical extension. So if this person on the left would look down, directly down from the position that they're at, we would see that they have flexibility down here, and they could look down, and then the upper cervical spine, because they have to look forward when they walk, would come up into extension. So we have the lower cervical spine, so C3, 4, 5, 6, 7 begins to look like it's more in a flexed position, and the upper cervical spine, 1, 2, and 3, looks like it's in an extended position, and so those combined together give us that forward head. So what we'll see then is weakness in the lower cervical and upper thoracic and anterior neck muscles. So lower cervical, upper thoracic, and anterior neck muscles tend to be weak. And then they're tight in muscles such as the levator scapula, the sternocleidomastoid, the scalenes, the upper traps. All these muscles that attach to that upper cervical spine are tight. Associated problems with this is typically a posture that is associated with TMJ or temporal mandibular joint problems, disc herniations, maybe in the cervical spine or even in the thoracic spine as it tries to compensate for this. TOS is thoracic outlet syndrome, and then Dowager's hump is the picture of the elderly woman that we saw on the other slide is the name for the posture when this gets really severe forward head with severe thoracic kyphosis. Again, we're just giving you another diagram of the dangers of the forward head position, and it starts with the head moving forward to compensate. Then the upper back begins to go into a kyphotic position. Then the lower spine, the lumbar spine, will begin to go into a more lordosis. So then we have the hips tilting forward. And so we have this domino effect, increased lordosis, increased kyphosis, increased lordosis, all the way down the back that can lead to lots of problems. So you can see how important just posture itself is. So knowing what your postural abnormalities are, perhaps you fall along this line and there are some muscles then that you could address to stretch out. Typically too, they want to, the rule is to stretch what is tight first and then strengthen the weak muscles after that. So start with muscles that are tight, stretch them, and then after a few weeks you start in on the strengthening. Here's another picture of somebody with cervical lordosis, thoracic kyphosis with a compensatory lumbar lordosis again. Tend to all kind of come together. All right, moving on to the hips. We're going to be talking about the relationship of the neck to the femoral condyles. And so if we take a femur and we look straight down from the top of the femur, here's the head and the neck, and then we have the condyles below it. And what we're looking at is this angle that if we take a line through the condyles compared to a line that goes through the neck and head, and we want to know, is that angle beyond normal. So we obviously can't take a measurement of this clinically. So if you had an x-ray, you could say, oh, this is 5 degrees, or however many degrees you are able to measure on the actual x-ray. But we can't see that, so what we do is we have to rely on what we see clinically. So if this angle from the head, so this is a right femur, from the head and compared to the condyles, if this angle is increased, we would tend to see what we call an anteversion, okay? And if you see somebody that has a true femoral anteversion, they tend to stand so that their toes make an A, so A for anteversion. So the tips of the toes are together and the heels are further apart. In this position, the hip actually has decreased stability. So somebody with an anteverted hip tends to have decreased hip stability. The opposite then would be retroversion, where we have a decreased angle between the head and the condyles. And that's somebody that toes out. So under retroversion, what you would see clinically is a toeing out posture, which actually increases hip stability, which can be okay, but it can also limit some of the range of motion. So anteversion, somebody would be in more of a pigeon-toed, or makes an A with their feet, and retroversion, they're toed out. Pretty good indication of what's going on potentially at the femur as far as rotation. Let's move down to knee alignment. If we look first of all from the anterior view in the middle here, we've got kind of a normal knee alignment. On the left side we have what's called genu varus, and so they tend to be more what we would call in layman's terms bow-legged. So we've got a lot of space between the femoral condyles here, and it actually does look like the leg is bowed out. The opposite then would be a genu valgus. So when they have their feet in shoulder width position, you can see that the knees actually touch each other. And so we got this L shape that kind of is made out of the alignment of their legs. So a genu valgus kind of makes this L posture in their legs, and the genu varus is more of a bow-legged position. So that's one knee alignment. There's another knee alignment called a squinting patella. So the patellas look like they're kind of looking at each other. This is typically found with somebody that has a hip anteversion. And when somebody has a hip anteversion, then they'll also have a medially rotated tibia. To compensate for that, however, when they walk, they tend to laterally rotate their feet. So it's an interesting thing that you'll see somebody with a squinting patella, they don't want to walk with their patellas looking at each other, so they'll roll their legs out or externally rotate, and so it looks like they've laterally rotated their feet. So somebody with squinting patella may walk with more of a toed out positioning because they don't want those patellas on the inside of the legs, they want them on the front of the leg when they walk. So the opposite of that would be a frog-eyed patella. Frog-eyed patella is when the patella are actually more on the outsides here, not directly laterally, but they tend to be more drifted out. And the hip is oftentimes found to be retroverted. The tibia is laterally rotated. So to compensate for that, because they won't want their kneecaps pointing more lateral or outwards, they'll roll in or walk more pigeon-toed. So that's the compensation for a frog-eyed patella. Genu Recurvatum. So clear on the right, we have more of a normal knee extension. And if we move to the left, of course, we have a significant, kind of almost looks like hyperextension, but a recurvatum of the knee joint, which can, again, lead to some problems. I actually had a professor in physical therapy school who at one time had worked as a certified athletic trainer as well, and she said that she would go down the line. She was an kind of an older gal, and she said she'd walk down the line of the football players, and anybody that had a posture with Genu Recurvatum, she'd pull them and say, you're at a high risk for an ACL tear, and you need to start an ACL prevention program. And that is tend to be true. I do see people that have an increased Genu Recurvatum. It's not unlikely that they've had some ACL problems. All right, moving on to lower leg and tibial torsion. So what we're doing is we're laying somebody supine, and if we have the patella pointed straight up to the ceiling, and the femoral condyles are lined up, so if we draw a line through the femoral condyles, it would be parallel to the floor, a line on the floor. And what we want to see is where does the foot lie, and that gives us an indication is the tibia turned or twisted at all. So when somebody lays supine and we have their greater trochanter is perfectly lateral, their condyles are parallel to a line on the floor, their kneecap is straight up, and we look at the position of their foot. And if we have a 5 degrees to 18 degrees from a perfectly perpendicular, we consider that a normal rotation of the tibia. If you have more than that, then that would be an externally rotated position. So in our notes, we have the athlete lays supine with the patella facing up. I think I have a picture of this. Here we go. Athlete lays supine with the patella facing straight up to the ceiling. One line is perpendicular or parallel to the table, so this line down here is parallel to the table, and the other line goes through the malleoli, and that's what she's pointing at is the malleoli. So we draw just in our minds those two lines, and we'll look at this angle. So if that's between 5 and 18, it's within normal. If somebody has a medially rotated tibia, we often see that that's associated with a genu varum. And if somebody has a laterally rotated tibia, so it's like if you took the distal part of the tibia and you twisted it out, we see that associated with genu valgum, and that's just how it kind of works up the chain. If we twist the tibia so the distal part goes out, a compensatory motion will be a genu valgum at the knee. It's often associated with child's posture, so somebody that, a child that sits with their legs in the W sit actually encourages lateral tibial torsion, and so this is called a tibial torsion bar. This is what's used or had been used years ago to fix it, and they'd actually have this brace that would stick onto shoes, and they would slowly try to twist the tibias back into a normal position. This actually is what I wore as a kid. I had bilateral tibial torsion, and I had a bar worn between the legs primarily at nighttime with it bolted into the shoes, and they would just rotate this a little bit more and more each night. So my right actually corrected fairly well. My left did not, and so if I remember to show you in class, I have a significant left leg tibial torsion that did not get corrected with this brace, but this is what they used to use years ago. So when we see somebody nowadays, you can sometimes pick this up in runners. Here's a runner on the left here with tibial torsion. So you can see kind of a toed out position if you can imagine that the tibia got twisted. And then their toes would be more in that position. And you can see how a toed out position would lend themselves to more of a genu valgus positioning, because you're toed out, you tend to pronate a little bit more. That drops the knee into an internal rotation. So works its way all up the way to the chain. So in comparison with the runner on the right, that does not have tibial torsion. Sitting posture for knees that encourages medial tibial torsion, so toeing in. So as a child, when I had lateral tibial torsion, I was told to sit actually like this as my bones would form so that they would be rotated in. But if you have a normal tibia and it's not torqued and a young person sits like this for a lot of their time during the day, they can actually cause themselves to go into a medial tibial torsion. All right, moving into arch position, so arch and foot. Pes planus is associated with pronation, so we've heard that term pronation and pes planus can sometimes be used interchangeably. With that, you see an everted calcaneus, and this person tends to have an unstable foot when they have pes planus. So here's somebody that's significantly pronated. You can see how the calcaneus is everted out, so the bottom is more lateral than the top, so that's an everted calcaneus. And the foot is very unstable. The muscles of these feet have to work really hard. In fact, a lot of people with pronated or excessively pronated feet, their feet are sweaty. Their muscles are working really hard all the time to give them some support in their foot. The other end of the continuum would be a pes cavus. It's associated with supination, so a high-arched foot, and very rigid. So if you hear somebody running on the treadmill that has pes cavus, it tends to be louder. They don't have that supple foot motion that drops them down into pronation and then resupinate. It's very hard. We joke about pes cavus runners giving themselves head injuries because they can't absorb the forces in their feet. And then you get associated problems. You can see this person already has hammer toe beginning to develop here. But this is called pes cavus. Another deformity that we'll see related to the feet is a hallux valgus. So we have this valgus deformity of the hallux, or the first ray, that takes place at the first MTP joint. And we actually have a bony deformation. So this is bone changes. If it gets too severe, they'll go in and they have to excise this bone, take it out, try to straighten this joint, and then pin it back together. So this is hallux valgus. So this is, we've addressed a lot of this already, just kind of a review on upper extremity posture deviations. We'll sometimes see it a lot with the shoulders too. Somebody that has rounded forward shoulders, forward or protracted scapula that's with internally rotated hands. I should have mentioned this during the posture eval, and you can check yourself just in a mirror, but when you stand upright, your palms of your hands in normal posture should land right at the sides. So if your hands tend to internally rotate and they're a little bit more on the front of the thigh, this is really severe in this picture, but if they internally rotate and they kind of lay on the front of the thigh, it's a good indication that you have a rounded shoulder posture. So muscles that are weak in this posture would be the rotators and the mid and lower trapezius. So those are weak on the back. And then muscles that are tight would, as you could guess, be the anterior shoulder. Your pecs are tight, the lats are tight. That's what kind of pulls this into internal rotation. And can lead to some severe problems, glenohumeral impingement being one of the more prominent ones if this is not corrected. I'm just going to, this doesn't really go with this slide, but I'm just going to kind of help you fill in some blanks on the next section about muscle imbalances. So causes of muscle imbalances, one is sustained shortening of the muscle and a compensatory sustained lengthening of the opposite muscle. So if you think of, I guess I can go back to this slide, somebody that has an anterior shoulders and they sit like that all the time, we're going to get a shortening of the anterior and then lengthening of the posterior, which means these tend to be tighter, maybe a little bit stronger, and these tend to be longer but weaker. Another cause would be overuse in sports activities. So there's a lot of emphasis on chest muscles and reduced emphasis on upper and back muscles, especially in certain sports. Swimming would be one, with particular strokes in swimming. The emphasis on the anterior over the posterior regions in boxing, unilateral activities such as racket sports, And our culture is such that youth are beginning to play these sports year-round, so they don't have an opportunity necessarily to work muscles in different planes or with different motions, so they tend to just adapt to the posture of the sport that they play most often. Other causes of imbalance, number 3, have aging. Number 4, joint abnormalities, so they might be hypermobile, so the joints just move a lot, not a lot of connective tissue, the capsules aren't tight at all, or hypomobility. Again, a lot of more collagen in the capsule would be tight. Number 5 would be injuries. Injuries, if you have any scar tissue adhesions, can cause some muscle imbalances. If you have muscle injury. Number 6 would be muscle strains, so scars, which we addressed a little bit. Decreased flexibility can increase stress at a joint. So all of those would be some causes of muscle imbalances. So in your evaluation, you're trying to figure out what is causing what. Treatment of muscle imbalances. Number 1, like I said, is lengthening the shortened muscle group. You need to start with that one. So whatever's tight, you start with exercises to lengthen those. Number 2 is strengthening the weak muscle group. Number 3 is educate the patient on proper posture for conscious correction. So they need to understand what proper posture is. So put them in the proper position, tell them how to, or have them work on trying to find that posture again in the clinic or the training room, wherever you're working, so they go back into their natural posture, and then they have to find normal posture so they can practice that. And then they need to do things like adjusting their rear view mirror in their car when they're sitting with good postures, so that over time, if they slump out of that posture, they can recorrect. And looking in the rear view mirror is a good reminder to do that. Sometimes we'll use taping done, not to hold them in a good posture, but simply to be a cue as to when they're slumping over. So sometimes we'll use a particular kind of tape, cover roll and some Leukotape, that we put them in a really good posture. We put cover roll strip on followed by Leukotape. Again, it's not pulling their scapula back, simply reminding them when they start to drift out of good posture. It's a cue that reminds them that they need to retract and depress the scapula and come back out of the postural deviation. Number 4 is encourage bilateral activities in unilateral sports. So let's talk about a tennis player. If they only use their right hand, you might say, oh, you should occasionally try using your left, or make sure that maybe you pick up another sport that uses both arms. So maybe you do elliptical for some of your off-season training, so you're using both of your upper extremities. And then number 5 is conditioning programs that include a balanced program. So again, most of the aerobic conditioning machines are symmetrical, but making sure that we aren't emphasizing one side over the other. All right, body mechanics is the last section. So it's the way that a body is positioned and used during activity. Basic principles is number 1 is keeping the back straight or in a neutral spine. So here we have a picture of somebody with excessive lordosis, and then we have somebody with excessive kyphosis. But we want to try to keep that back as straight as possible. Number 2 is strong abdominals. On your sheet, strong abdominals. So they should be able to contract their abdominals when they're doing some sort of lifting. Number 3 is that the stability could be maintained by a low center of gravity, a broad base of support, and a stance in the direction of the force applied. So if they're pushing forward, for example, here, she's got a stance that's in the direction of the force that she's applying. So these are all ways in order to improve body mechanics. And then number 4 is strong quadriceps. We're told to lift with our legs, but if our legs aren't strong, that doesn't help, so we need to perhaps train and get strong quadriceps. Body mechanics during daily activities. When we talk about proper lifting, that's primarily the one that we address. There's some things that we might have to instruct a patient if they have back pain, or we need to teach them good body mechanics during lifting that we'll want to address. The first, of lifting objects, things that they need to be reminded are to face the object directly, so they wouldn't come at it from the side, to stand close to the object, to flex the hips and the knees. So you got to make sure that they've got flexibility in those joints, that the back is straight, and that they're able to tighten their abdominals. So kind of a co-contraction in the core. Pushing and pulling the objects very similar, but we're going to add, there we go. We're going to add using the legs to this. Carrying objects, we have to alternate hands, keep the object at waist level. I think of when I was working in Nebraska, and I would see some of these guys that came in from the farms of the ranches, and they would carry 5-gallon buckets, always in a left hand or something like that. And so you try to teach them, well, you should carry it in your right hand once in a while, or try to keep that bucket more at waist level, which is a difficult thing to switch up if you've been doing it for one way your whole life. Rising and getting out of a chair, it's interesting that you think we'll just get up. Actually, some people need to be instructed on how to go from proper sit to stand. So a couple instructions would be to slide forward in the chair and keep your back straight, push up with your legs and arms. So if you're sitting in a chair right now listening to this, you can test this, slide clear to the back of your chair and try to get up. It's more difficult than if you would slide to the edge of your chair, lean forward keeping your back straight, and use your legs and your hands to push up. So, instruction for body mechanics during getting off the floor. The instructions would be to roll onto your side and then push up with your arms. If you're on a bed, then your legs would swing down at the same time that you push up with your arms. Those are general instructions that you should know. You should be able to instruct somebody. I know on the exam I ask you, here's a scenario, and you need to give proper body mechanic instructions for this person's activities of daily living, which include lifting an object, carrying in groceries, getting up out of a chair. So you should be able to give them some verbal instructions on this. I see on your notes says body mechanics in athletic events. They're very similar, just with the basic principles that we've already gone over, so you can kind of just read over those. And then the last point we want to address is body mechanics for the rehab specialists. So they do a lot of work. It's pretty easy to get injured in the back, or you can't produce enough force maybe in your arms, and so you torque your body or use positions that put you at extra strain. So here's just some cues on that. Equal distribution of the weight over both feet, so try to avoid standing on one foot a lot during the day. Feet in correct alignment and in the direction of the forces that you're applying. So even though she's kneeling here, she's got her body positioned in the direction of the forces that she's applying. The force is applied from the legs, not the arms. So anytime you can do joint mobs and you can apply the force through the arm, but actually you're pushing from the leg through the arm, that's going to be better. So force applied from the legs. And number 4, keep the back straight or in neutral. Number 5, moving one foot to the other foot and back again. So again, you're not always standing on one leg. And then keeping upper extremities relaxed and in proper alignment.